in introducing our keynote speaker, I am reminded of the butterfly effect. A butterfly flaps his wings, or her wings, and sets into motion a series of events which alter or illuminate the lives of millions. Dr. Paul Terasaki is our butterfly. I can almost guarantee that every person attending the APC or any person throughout the world who is involved in any sort of transplant can trace their roots back to Dr. Paul Terasaki. His awards are numerous. If I was to list them, I probably would be here for 15 or 20 minutes, so I think they're listed in your program. His impact is undeniable. I would like to introduce our keynote speaker, Dr. Paul Terasaki.
Thank you very much. I'm very humbled by this honor, and very pleased to have this chance to tell you a little bit about the old days and what some of the things we did before. Let's see now. All right. Okay. We think that to do this kind of a work that we're trying to do here, there's two main components, two things that we have to keep in mind. First of all, should be a national pool, maybe an international pool. That means that the patients are very highly sensitized. HLA, there are many, many HLA types. So somehow we've got to get a whole bunch of people together in order to get a match for them. And the second thing we're really committed to is that we must ship the kidneys. Shipping the kidneys is the key to making this thing work. And I noticed that this National Kidney Registry was the first registry to take my advice. But I should also tell you that we wrote a paper about this. In order to do shared kidneys, you should ship the kidneys. And this paper was rejected by 4 different transplant journals. And we had really a very bad time to get it published. And I see that Dr. John Nadurian is here because his journal, Clinical Transplantation, was the only journal that accepted our paper. So we're very happy that at least it's in the press somewhere. Okay, so for the highly sensitized patients, desensitization is very expensive, very time-consuming, traumatic to the patient, really inefficient. When the antibodies are very high, it is very, very difficult to get those antibodies out of it. So the only hope for the 10,000, there's probably more than 10,000 patients in the United States who are highly sensitized. That means have a rate of more than 80%. And so with a large donor pool, we should be able to get a negative cross-match and a successful donor exchange. So the larger the pool, the greater is the chance of getting a negative donor for the patient. That's obvious. And so this is something that we should continue to do, is to accumulate and enlarge the pool. Okay. So the National Kidney Registry has now done 120 of these kidneys, and we really think that this is quite impressive in this short period of time to do that. But we think that the donor should stay in the hospital, the same hospital as the recipient, place where he's living and where he's comfortable. But the kidney should fly. Now, one of the comments, unbelievable comments of a reviewer of our paper said, well, if you're going to ship the kidney, what happens if the kidney goes down with the airplane crash? And our answer, of course, is that it's much better to have the kidney crash than the donor crash. And so the donor usually stay at home and recover and put his kidney to risk by letting the kidney fly out there. And it's much more convenient to stay in the hospital and not suffer the inconvenience of going to an unknown city, unknown hospital, unknown doctors. For the recipient, it's much easier to get the kidney in a box, in a cardboard box. Here's the kidney dropping out of the air for the recipient. And this is much better than to deal with the donor. I mean, the donor, if you have to look at the donor might be fat, might be raised, might be ugly. You never know. But it doesn't matter, because the kidney comes in a box and it works. That's all you need. So 40 years ago, what we did, but this is also for a little bit different reason. 40 years ago, we developed tissue typing, and we saw that in one place like Los Angeles, it's impossible to get a matched kidney transplant. There are too many HLA types. So I decided that the most important thing for us to do is to figure out a way to ship a kidney. And in those days, the kidneys used to be put on perfusion machines. But I was determined to develop a cold storage solution, and was very lucky that a surgeon from Australia, he had done his residency in England. He came to Los Angeles to learn tissue types. I told him, no, you don't need to learn that stuff. We'd like to have you develop a cold storage solution. And so we hired actually 2 nurses and another doctor, so 4 people. And it's amazing that we had to go through $200 to do this, to develop what's today called the common solution. Actually, I also suffered for that, because all that money I took out of NIH contract for tissue typing and put it into preservation. But anyway, we finally did develop this cold solution to send to HLA matched recipients. And so in 1970, we took out the dog kidneys and shipped it to show that our method works. Actually, we published it in Lancet in 1969, and nobody believed it, even though we published it in Lancet. And so we decided, okay, we're going to send this kidney to London.